Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jeanne Sarnosky, and on today's program we're going to learn a little bit more about the hereditary gene for breast cancer. And we're lucky enough today to have on our program Nancy Ferzoco, who is at the Seifer Women's Health and Imaging Center in Falmouth. And we're taping in Yarmouth, so she came a long way. Thank you for doing that. I appreciate it.
Thank you for having me.
So, in order to get sort of the audience familiar with who you are, I always like to know how long have you been on the Cape and involved in healthcare, and what maybe attracted you to this particular position that you're in today.
Thank you. I moved to the Cape 12 years ago, and I took a job at Falmouth Hospital. It was temporary until I finished graduate school, and then when I finished graduate school, Mary Ann Wagon, who was my preceptor in my graduate program, she was retiring, and so we switched jobs. She went to teach at UMass Boston, and I took her job as a breast care coordinator at Falmouth Hospital, so it ended up to not be a temporary job. So I've been doing that now for 8 years.
As those things go, right?
Yes.
I think the previous guest we had was a volunteer in the position that she's in, and then one thing led to another, and she became manager of the program.
Yes.
Yeah. Did you have a particular interest in breast care, breast cancer, or did it just go that way?
I literally fell into it. I've always loved women's health, especially in the program that I was attending at UMass Boston, but women's health, it can run the gamut of,
right.
And breast health really just is such a big thing. I love working with women, and I love women's breast health.
Oh, yeah, yeah. So the hereditary gene is relatively a new discovery, is that right?
Relatively. I mean, it's been out there for a few years.
A few years, yeah.
The breast cancer gene, the BRCA1 and 2 gene.
Does that stand for something?
It does. The BRCA stands for breast cancer 1, and the BRCA2 gene stands for breast cancer 2. They were actually on gene 13 and 17, but they shortened the names.
Oh, okay. So what's the number? Is the first one discovered, or?
Probably, yes.
Oh, okay.
And the second one has more to do with more ovarian cancer, but the whole BRCA 1 and 2 is also called HBOC. It's hereditary ovarian and breast cancer, so those two diseases are carried on those two genes, which are normally normal genes. When we talk about the BRCA, it's actually a mutation of those genes. The mutation being that they can't fix the DNA when there is a problem. We're born with a mutation when we have the BRCA. We're born with one mutation. And as life goes on, we get a second mutation, and then we have breast cancer. Normally in the general population, we're born with 2 healthy genes.
Ah, all right. Yeah, that gets a little tricky, right? Yeah. So do you automatically go to people should be tested?
No. The first thing to know is a person's medical, personal, and family history of breast cancer. We would get an idea with a patient coming in that had breast cancer diagnosis at 50 years old or younger than 50. And then you would start to ask questions about the red flags to try to ascertain more information.
So what is a red flag?
The red flags are a group of questions that a provider would ask a patient. Are you a patient that has breast cancer at the age of 50 or under? Do you have ovarian cancer? Do you have male breast cancer in your family? You have Ashkenazi Jewish ancestry? There are other family members with an HBOC mutation, a known mutation in the family. And if you're a patient that has had another breast cancer, and now you have a second primary cancer.
Okay. So is it safe to say family history plays a large role in it?
Family history plays a large role. It's important to get an accurate family history, and when we're looking at a family history, we're looking at the family history from the mother's side of the family, first, second, and third degree relatives, but we're also looking equally as important as the father's side of the family, because we get half our genes from our mother and half from our father. So, and sometimes it's difficult to get a family history because it seems like everybody in the world's adopted because nobody knows what anybody died from. It wasn't a discussion back then.
Oh, I think that's right.
Those words.
Yeah, or they didn't know.
Right.
They didn't call it that.
They didn't
back
call
in
it
the day.
ladies' problems.
Yeah.
But they didn't use, breast or ovarian. It wasn't a conversation.
Terminology, yeah.
But too, sometimes the patient knows that they need a little bit of family history, so they'll make a few phone calls, and sometimes you get a few more pieces of the puzzle.
Oh, yeah. Now, how, you briefly mentioned it, but so viewers can understand, how far into the history do you go generationally, and is it aunts and uncles and
first, second, and third degree relatives?
So
as far as you can go, that would be the people in your family, your sisters,
okay,
and then your aunts, your first cousins, your second cousins, your great aunts.
Okay.
And with the Ashkenazi Jewish ancestry, then that is a pool that can go out to the fourth generation, fifth generation also.
Wow. So does it go back? So if it skipped a generation, of course we wouldn't have known because they didn't call it that, but maybe great grandmother
It may have skipped a generation because if you have inherited mutation yourself, only half of your children are going to have that DNA. If you have a mutation yourself, then half of your sisters and brothers, or half your there's a good chance that somebody else in your family is going to have that particular mutation, or a cancer that's very similar to yours.
Right. Would it be identified previously as a mutation, or at this point we're just saying known breast cancer, and then
we're just getting information. We're just getting information
for the family history piece of it.
Yes.
And then if there are those red flags, so there's 10 questions?
Yeah, there's 7 or 8, and as DNA testing and everything revolves, as you get on that checklist and there's more and more pieces of the puzzle, then you might want to move further and start talking about having the testing done just to get more information.
Oh, yeah. So do you have a criteria such as 50% of the questions or greater, that's when you go get tested, or it's not quite that simple?
It used to be almost that simple. There was a sliding scale, and you could come up with an actual percentage number of the prevalence of your chances of having inherited the mutation, but it's not so rigid anymore. Things are a little more fluid with the questions, and the testing is much more easier to do. It's not you have to be 10% chance, or you have to be 15% chance.
So if now we're at a point where we've answered the question, so there's a lot of red flags. We'll say, okay, there's a lot of red flags. So then, is it up to the patient to decide whether they'll be tested?
It is. It's usually the patient will be the one. Sometimes when they just come in for their mammogram and say, I have a lot of concerns about my family history, and I've heard about that testing that can be done to find out if I need to have it done. And we start off with saying that only 5 to 10% of all breast cancers are inherited from your mother and father. Only 10%. If you think of that as a pie. So another great piece of the pie is it's familial. It runs in the family, but they're not all the same kind of cancers. And the whole rest of the piece of pie, which is the majority of the pie, is just environmental, sporadic. We don't know how anybody got it. Nobody lives a lifestyle to bring it on themselves. It just happens. So it's a very small portion of breast cancers that are inherited from the mother and father.
Oh, wow. That's kind of nice for the mother and father to know.
Right.
I don't feel too bad because so much of it is environmental.
Right.
Can one be a carrier and never have it become something bigger?
Yes. You can be a carrier.
Oh, yeah. So you could have a mutated gene in there that never decides to be
one mutated gene onto your child.
Renegade or whatever.
That's right.
Yeah, it doesn't present as anything.
Right.
So let's say someone decides then to go be tested. How long does it take to
The
get
test
the result? What is the
is
test?
pretty quick
Yeah.
now. It's a
Okay.
DNA test. It's
So blood test?
It is. It can be a simple blood test, or even easier now. They have buccal swabs that you just swish,
Yep.
fill a tube and send it out. Before that's all done, the patients had a lot of education, so that by the time that they're signing their consent form, they're definitely educated, and they know they have asked a lot of questions, and they feel confident that this is going to benefit them and their family, the information.
Right. So they're feeling not or less nervous about the outcome of the
right.
test.
Mm-hmm.
So let's say they're tested, it comes back positive.
Mm-hmm.
Then what?
Now, if the test comes back positive and the patient is, say, diagnosed with breast cancer, so now the question is, should I just have a lumpectomy? Should I just have a lumpectomy and radiation? Or, because my chances, the risk of contralateral breast cancer, being the other breast,
Okay.
the chances of that having a breast cancer, the risks are very high compared to somebody that is just coming in with a breast cancer that is not BRCA positive.
Oh, okay.
So their chance of reoccurrence is very high. So they might opt to have a bilateral mastectomy, which would reduce their chances of breast cancer recurrence down past, up, the safety net is 90%.
Right, right. So automatically, the positive BRCA test is positive for breast cancer. That
It
means the
doesn't
same
say
thing.
that you have breast cancer. It says that your risk of having inherited the mutation is very high, that it's there. And your risk of having breast cancer, say at 50 years old, 2% of the general population will get breast cancer. 2%.
Okay.
At 50 years old. Now, if you have a BRCA mutation at 50 years old, your chances of having breast cancer are 50%.
So instead of 2 out of 100, it's 50 out of 100.
Mm-hmm.
Okay.
So you see the significant graph growing.
Sure.
And also, if you, the general population for ovarian cancer, a lifetime risk of getting ovarian cancer for the general population is only about 2%, whereas with the BRCA mutation patients, their chances go up to 48 to 50% in their lifetime.
Wow.
So it's not a matter of are you going to get breast cancer or ovarian cancer, it's a matter of when.
So then what happens for next steps at that point? Then it's just a big discussion about
It is.
what do I do now?
It's a personal discussion. Some women opt to have double mastectomy and to have then maybe implants put in and to have their ovaries removed because of the estrogen. 95% of tumors are fed by estrogen.
That's good information to have out there.
Gives food to the tumors.
tumors.
So that's why a lot of people will have their ovaries out as well. If they're too young and they haven't had their families yet, they may choose to go with just very careful and surveillance to check for ovarian cancer. They may go
And breast cancer too?
and breast
Would they-
cancer
yeah?
too.
Yeah.
Mhm. Yeah. So
So
they
they
would go
might
for
just be.
mammograms
So that would be
early.
the conservative side. Is how fast does it move? Would they go every 6 months?
They
to
may get to
probably?
do that, MRIs, more modalities for checking, clinical breast exams instead of every year, have a clinical breast exam every 6 months by a clinician, and also you would definitely get good at doing your self breast exams every month.
Right.
And that could be starting from 18 to 25. Wow. Especially if the patient's mother was in her 30s or 40s
Right.
with her breast cancer.
Is there an age where people start having the discussion if they know there is a family history?
Yeah, say if you have
When
a
you said 18,
mom
that's what made
that
me think
was
of it,
35 years old when she had her first breast cancer occurrence and she was BRCA positive, the American Cancer Society recommends that the daughter start her mammograms 10 years earlier than the mother had her first diagnosis.
Oh, yeah. So you see teens
Mm-hmm. Yeah.
getting checked.
Yes.
Yeah.
And then, there's a lot of options. You can go to the, hospitals in Boston where they have trained people to talk, and you can have your eggs frozen, so these young girls don't feel as though they have to get mastectomies in their 20s and 30s and having their ovaries out. They need to be able to, you know, have their children be all set, and then maybe move forward with thinking in those terms of protecting themselves into their middle ages.
Do you run into people then, once they know they have it, not inspired to have children because of the passing on?
No, I never had that.
Oh, yeah.
No. You mean because they're afraid to have the gene go on?
Yeah.
No.
They have that power to stop that gene right
luckily
here.
we don't see a lot of young people.
That's nice. That's a blessing.
Do a handful now and then, but not like in the cities.
So it's the breast cancer and the risk of ovarian. That's all part of the same.
Yes.
Other cancers or?
Other cancers that are associated with the BRCA is also pancreatic cancer.
Ooh.
So with the BRCA mutation, there is a small risk of pancreatic cancer in men and women, and there is an increased risk of prostate cancer in men.
Wow, interesting. Yeah. So, and breast cancer in men too, or not?
That's interesting. Men are usually left out of the breast cancer conversation, but the truth is 1% of all breast cancers are found in men. And men do have breast tissue.
Right.
They don't have the breast glands, but they do have the ducts. And so they can have breast cancer, and they do, it's an autosomal dominant disorder, so they can inherit a breast cancer gene from their mother or their father as well.
Oh, right.
So there is literature out there for men. I mean, if anybody feels a lump or anything, just have it checked out. We can do mammograms on men.
Oh, yeah.
And, you know, oftentimes it's just that galactoremia, it's just that inflammation. It's usually just antibiotic and warm packs or whatever, but you know, have anything. Lumps shouldn't be there. Just have them checked out. Most of the time, it's completely benign, which is a good thing.
Yeah, yeah. Do they have calcification like women do?
Not so much. I've never seen. I don't know about that.
Okay.
I've never seen a stereotactic biopsy done on a male, and stereotactic biopsies are done very frequently on females because of calcifications. It's a good way to be able to sample that.
Right, right. Now, are there certain individuals other than the family history that are more at risk?
The Ashkenazi Jewish ancestry people are at very high risk. Their risk is because of the Eastern European, the people didn't move out of the area for many years. They stayed. So the DNA pool got heavy. Right. Yes, the founder effect. And so when you test those people, if there's, you know, because that's one of the red flags that we talked about.
Wow.
If you test those people, their chances of having a BRCA mutation is 1 in 40, whereas the general population is 1 in 400.
Wow.
So they have their own sliding scale.
Yes.
When we used to use the sliding scale.
Yeah, yeah. So that population step probably, huh?
Yes.
Yeah. Wow. Is it a test that insurance covers?
The insurance has gotten very, very good about the BRCA analysis testing. Most the patients end up maybe having $100 or $275 copay, and then the Myriad company that does the testing, they would help with payments. They want to have this testing done.
Because in the end, it'll save them.
It's a good thing.
Yeah, it is a good thing.
It can prevent cancer. It can be a preventative measure.
Is there data and information out there now for the success or the results of this? Now that this has been in place, is it showing up as a wow, good thing for some of the breast cancer sufferers?
It's a very good thing for people to have the BRCA done, to know how their medical management should go, because if you know that you are BRCA and you're not waiting for the other shoe to fall, because now you've taken care of it. You've done all this preventative surgery.
Right.
Or you've done this preventative surveillance. What you know is powerful, because it gives you the right to make choices.
Yeah. So medical management, is that an option? I guess I didn't.
Medical management would be the surgical, the surgical prophylactic, meaning in case it's doing like before you have breast cancer, having your breasts removed. That would be prophylactic, doing it ahead of time to prevent. Or
there's been a little bit of that in the news lately. Is that right?
There has been, yes. And those people definitely know that they have the gene. They're not just doing a very, big surgery just because they're afraid of losing their breasts.
Right.
They have had, they've had this education brought forth to them, and they've probably had information from their family that put all their pieces of the puzzle together and made them come to those terms.
Right.
It's not there's nothing conservative about it, but it definitely is
takes care of the problem.
Yes, it does.
Yeah. What is the percentage? Do you know, after
I don't.
something like that? It must. When we talked early on that it must go down to nil practically.
Well, if you have a prophylactic mastectomy, your chances are reduced by 93% of having any breast cancer again. Even though you have a mastectomy, not every piece of breast tissue is removed. There's some breast tissue still there, but you're reduced to 93% of not having any breast cancer.
And those odds
and to have your ovaries out, your chances of having ovarian cancer are reduced by 70-80% in your lifetime.
So those two are hand in hand, right?
They are.
Yeah. Do people follow through like that? Both surgeries at the same time?
Pretty much.
Generally speaking.
Yeah.
Wow, that's pretty dramatic stuff. Yeah.
And sometimes people will say, I don't want to have the surgeries, but I'll go on the tamoxifen. I'll go on the oral contraceptives to reduce my chances of having ovarian cancer, reduces it by 50%, or to have...
because the estrogen feeder is changed or whatever, yeah.
Yes.
Eventually, do they opt for the next step? Probably.
Yeah, yeah.
Because it just gets that scary.
Yeah.
Wow. Now, with the new health insurance, do you know, is it considered pre-existing condition or?
Well, what happens is the federal government wasn't going to have that happen, because they wanted people to be able to have DNA testing and to be preventative and be able to have their medical management the way that they needed and wanted to have it. So the HIPAA laws, which protect our banking and our rights and our privileges, they set up the HIPAA laws, the Health Portability Act, and then there's the new, I think it's from 2006, the GINA, which is genetic, prevents genetic people from being discriminated against, and from also having further DNA testing or having your family DNA tested. So it doesn't affect your jobs or your health insurance.
That's
I'm
great.
not sure about the life insurance.
Yeah,
but
time will tell.
Yeah.
Yeah. We have about 2 minutes left, believe it or not. Does that go fast? And I just wondered if there anything that we haven't talked about that you wish people would know? Either about getting tested or don't be afraid. It's really a good thing.
Well, don't be afraid. You can call us and we can go through all this information in a sit down, and you can take as long as you want with, slides and graphs, and you don't have to sign the consent form. We can just hold on to your paperwork, and you can decide to come back a month or two later with your specimen after you talk to your family. Because when you do get these results, sharing them with your family is a big thing, because why have it all to yourself?
Right.
So
you have to.
Talk to your family and bring them into the conversation.
Yep. But number one flag is family history, then you should think about it. Yep. Very good. Well, thank you, Nancy, for being here today. I appreciate your time. It's good information, really good. Yeah. Okay. And I'm Jeanne Sarnosky, wishing you good health and good health care.